And next presentation, MICS-MiECC current evidence, Dr. Antonitsis from Thessaloniki.
Okay, thank you very much. Thank you, Serdar, for this concise overview of MIECC and minimal invasive cardiac surgery. So as I listened to your speech about the benefits for the surgeon, the anesthesiologist, and the perfusionist, and I'm looking at Mike Van Driel, I would say that it's not only these three parts, it's that the patients want minimally invasive surgery at all. The patient wants enhanced recovery after any type of surgery. So in Greece, they ask us, are we going to do it laparoscopically or things like that? So as long as you have the consumer that wants something, then it is definitely something that we need to pursue. Otherwise, we cannot be a scientific society and, let's say, the society that moves to another way. So I will just present you the current evidence, but with this sense, if the consumers want it, the industry will follow, and we need to follow as well. So we have the ISMICS Congress in Athens. I'm just advertising it, and we have to combine minimal invasive cardiac surgery with, to be the, let's say, if this is considered an advance in cardiac surgery, we need to make it even more advanced. So what is minimal invasive cardiac surgery? According to the definition, minimal invasive cardiac surgery, the term minimal invasive refers to a small chest incision that does not include a full sternotomy. This is the case back from 2008. But is this really the case? Whoever met Hugo van der Ven, I believe this is the man behind minimal invasive cardiac surgery. He invented minimal invasive cardiac surgery in the era of conventional cardiac surgery. And he wrote in 1998 that the objective factors affecting the degree of invasiveness are the surgical approach and cardiopulmonary bypass, and that comfort and cosmetics may also be improved. But is this truly minimal invasive cardiac surgery? He was asking back in 1998. Or is it simply fashionable minimal invasive cardiac surgery? So he said that minimal invasive cardiac surgery is cosmesis, alternative access, plus cardiopulmonary bypass. But as you see over the years, this part was excluded, and we actually focused on an alternative approach. The clear message of this speech is that minimal invasive cardiac surgery without minimal invasive extracorporeal circulation could not exist, as Hugo van der Ven was implying. So in order to provide the best care for the patients that the patient requires to have minimal invasive surgery, yes, with a better outcome in terms of enhanced recovery, we need to provide minimal invasive cardiac surgery with minimal invasive extracorporeal circulation. You can't have one without the other. That's why perfusion matters, and it will always matter in cardiac surgery because it's related to any type of cardiac surgery, and it is related actually to the complications that we see after surgery. The need to perform minimal invasive cardiac surgery actually promoted the optimized perfusion circuits. I mean, in terms of changing cannulation strategies, so moving from the central to peripheral cannulation, changing aortic cross-clamping, adding vacuum-assisted venous drainage to perfusion, a little bit changing myocardial protection from blood cardioplegia that we all know it's better to the Brett Snyder cardioplegia that we all know it is not the best, but it suits to the minimal invasive cardiac setting. So we started to doing modifications to apply to minimal invasive cardiac surgery. And as Dr. Gunaydin pointed out, we have increased cross-clamp time and cardiopulmonary bypass time in minimal invasive aortic surgery and in minimal invasive mitral surgery. Is this important? Yes, it is. As you can see in this study that was published a few months ago, aortic cross-clamp time, the minimal invasive cardiac surgeons say that aortic cross-clamp time correlates with mortality in mini-mitral international registry. So they themselves say that as we increase the cross-clamp time, we increase mortality. So this means that we do not need only to change the access, but we need to improve physiology and perfusion in order to have good results with minimal invasive cardiac surgery. Otherwise, something is missing. Okay, you can see that by increasing cross-clamp time, mortality is increasing. That's why MIECC was actually incorporated, even from 2011, in the consensus statements for minimal invasive cardiac surgery. because it will further improve, as you can see, ventilation time, ICU stay, postoperative delirium, red blood cell transfusion, as we earlier discussed, and actually it provides a more physiologic environment. This was evidenced by many studies. So especially in terms of neurologic protection and reducing blood transfusion, MIECS significantly assists minimal invasive cardiac surgery, even robotic, totally endoscopic coronary artery bypass grafting. I do not want to go into details. Okay, so these go together. So while we need to implement these ultra fast track protocols that we definitely say that the patient wants, which are the 4 pillars that Ancona is suggesting? Reduced chest incision, this is 1. Rapid deployment, let's say valve, it's the 2. MIECS is 3. And fast track anesthesia and ultra fast track anesthesia and recovery is the 4th pillar. But if these 4 pillars, when combined, lead to a better outcome, we need to have why each one of the 4 pillars is good. I mean, if the rapid deployment aortic valve replacement is good, it's not only good because it's in the setting of minimal invasive cardiac surgery. So the rapid deployment AVR, is it good for every case? Or we just use it only in these situations? So that's what I'm going to tell, that we need to implement the best features in every discipline in order to have the best result. Okay, in order to have the patient 4 hours after surgery doing physiotherapy rather than being intubated. And the critical component of the Ancona group in CPB management is enhanced use of minimal invasive extracorporeal circulation with these procedures, and in terms of reducing complications rate. So integration of MIECS to minimal invasive cardiac surgery transforms it from a limited access surgery to a more physiologic cardiac surgery. And this is what the patient needs, and we need to adopt it with the assistance of the industry in order to perform, in order to achieve this. We have seen this, actually, these quotes by Bob Chiai in yesterday's presentation, but minimal invasive cardiac surgery and minimal invasive extracorporeal circulation go together. We need to change the conduct of surgery. That's correct, and we have to work together to have the better outcome. That's also correct. So actually, as you can see, minimal invasive cardiac surgery has a pillar of access, a pillar of technology, and a pillar of technique, and the same applies to MIECS with the circuit, with the peripherals, and the strategy of goal-directed perfusion and point of care that we have extensively discussed yesterday and today. So all these contribute to the surgery that the patient wants. The patient sees the incision, asks for a limited incision, but he actually asks for a limited derangement in his physiology and not only for a limited incision. This was actually reflected in our position paper, that integration of MIECS advances minimal invasive cardiac surgery. So the modern operating theater, this is our operating setup, will consist of the surgeon that is doing minimal invasive cardiac surgery, let's say for a limited incision, the anesthesiologist who will do enhanced recovery, including the whole protocol from preoperative management to nutrition, the perfusionist who will do minimal invasive cardiac surgery, applying minimal invasive extracorporeal circulation, applying goal-directed perfusion techniques and monitors everything. And this is actually physiologic cardiac surgery, okay, with MICS and MIECS liaised one with the other. Thank you very much. This was a clear message.
Thank you very much, Polychronos. We agreed that we'd keep the discussion to the end to see how much time we still have left.